Buenas tardes. Muchas gracias. Estoy muy contenta de estar aquí otra vez en Colombia. Gracias, mis amigos. Y no hablaré portuñol porque vosotros no merecéis. Hablaré inglés. Pero para las preguntas puedo hablar en español. So I was invited to talk about advanced endometrial cancer, and this is a very exciting topic as there are so many advanced recently in the last year. So please pay attention to my conflicts of interest for this presentation. And Dr. Pierre asked me to bring a clinical case, and we are going to discuss it. So this patient is Sarah. The picture and name are fictitious. Sarah is 58 years old, no comorbidities, and she presented with pelvic pain and abnormal vaginal bleeding. Pelvic examination, no significant abnormalities. Transvaginal ultrasound, a mass detected in the uterus. And she was submitted to a biopsy, and she has uterine carcinosarcoma. Pelvic MRI with a mass in the uterus, and whole body PET-CT without evidence of metastatic disease. So this patient has stage 3 carcinosarcoma. This is the MRI, and she was submitted to surgery up front, and the stage 3 was confirmed. Here is the biomarker status, MS microsatellite stable, HER2 3+, estrogen and progesterone receptors positive, p53 mutant, L1 chem positive, HER2 again, and pole status not available. And she was submitted to treatment with carboplatin and paclitaxel, and then followed by radiotherapy according to PROTECT 3 or the GOG 258. She had complete response, and 1 year after the end of the treatment, unfortunately, she complained of coughing and shortness of breath, and chest CT and PET-CT confirmed disseminated pulmonary metastatic disease. So carcinosarcoma metastatic to the lungs after treatment with platin and paclitaxel, after 1 year of treatment. So the question here, what treatment would you recommend for this patient at this stage, and why? Would you consider a new biopsy? Would MS status impact your treatment choice? We know that around 20% of the patients have a shift in the microsatellite status after first-line treatment. So there are so many questions. I will bring many trials for you so we can make our decision together. So focusing on the advances in the endometrial cancer treatment, and the last time we had an advance and incorporation of drug was 20 years ago when the GOG 204 was presented, 177 was presented, bringing paclitaxel combined to doxorubicin and cisplatin for patients with advanced disease. Then another GOG study showed us that anthracycline was not necessary combined to platin and paclitaxel. And for 20 years, we have been treating our patients with platin and taxanes. And last year at SGO, 1 year ago, 2 very important trials were presented. First of all, the RUBY trial. The RUBY trial trialed dostarlimab combined to chemotherapy in patients with advanced disease. In first line, our patients submitted to chemo in the adjuvant setting at least 6 months free of disease. And importantly, our patient was included in this trial. Carcinosarcoma patients were included in the RUBY trial. And patients were submitted to the combination, and then the investigational arm was dostarlimab combined to chemo and then on maintenance. And primary endpoint of the study, progression-free survival and overall survival. And the curves are beautiful, especially for those patients who are mismatch repair deficient, for those patients who have microsatellite instability. And you can see in those curves to your left, on the bottom, and that the difference is huge. The hazard ratio is less than 0.3 for those patients who are mismatch repair deficient. But there is also a significant gain for the overall population when the dostarlimab is added. And when we focus on patients who are proficient, there is a benefit, but it's smaller. The hazard ratio on PFS for mismatch repair proficient patients is 0.76 compared to 0.28. And also there is a tendency to overall survival gain, so the curves are separate for the overall population. The hazard ratio is 0.64, but when the trial was presented 1 year ago, it was not significant, that there was no statistical significance. It was p.00221, but it was determined that only 0.0017 would be positive. But GSK has announced that the trial is positive for OS. Dr. Mirza says that it's really positive, that the difference is huge. Okay, and another very important phase 3 trial was presented at the same SGO. Here, they study 18 comparing the keynote, comparing the same combination with pembrolizumab. Patients had to have an interval free of chemotherapy if submitted to chemo in the adjuvant setting of 1 year, and carcinosarcoma patients were not allowed. But the difference is huge again, especially for those patients who are mismatch repair deficient. And we see here the same hazard ratio of 0.3. So it's clear for us from these two trials that immunotherapy is essential in first line for those patients who are mismatch repair deficient. And in this trial, the benefit for the patients who are proficient was bigger than in the first one. The hazard ratio was 0.5 compared to 0.7 in the dostarlimab trial. But it was not the end of the year. 2023 was a very special year for many cancers, and it was not different for endometrial cancer patients. Also, the ATTEND trial and the DUO-E were presented at ESMO last year, so 4 positive trials. The ATTEND trial, same population, patients with advanced endometrial cancer, submitted to chemo with platinum and paclitaxel, here combined to atezolizumab. And there is an important difference. Patients were submitted to immunotherapy combined to chemo, and then immunotherapy on maintenance till progression of disease, and this is difficult because the cost for us would be very high. But again, the study was positive, the benefit was huge, especially for mismatch repair deficient patients. Hazard ratio, again, 0.3, same history for all trials, and it was also positive for all comers regarding PFS endpoint, and we don't have OS data. And the last positive trial, the DUO-E, same design, patients with advanced disease submitted to chemo, immuno, and here the immunotherapy is durvalumab. And there is another question on this trial. There is one arm adding PARP inhibitor and durvalumab. So there is an arm combining durvalumab and olaparib. And see here the results. When we compare patients who are mismatch repair deficients, the curves are overlapped, so it doesn't seem to be any benefit of adding olaparib for those patients who are mismatch repair deficient. But when we look at the proficient group, the durvalumab and olaparib group seems to be better than the durvalumab alone group. So a new strategy, we need more data on this group, a very expensive, potentially more toxic because we are adding PARP inhibitors here, but there is a sign of efficacy in this group of proficient patients. And just to talk about all the trials, there is one negative trial. So this trial tested avelumab in the same clinical context. It was a phase 2 trial, but again, avelumab was negative. All trials of avelumab in gynecologic cancers have been negative so far, and it's another one. So in this phase 2, the trial was negative. So I've tried to compile all the data for you. So in 2023, there were 5 randomized trials, 4 phase 3 trials and 1 phase 2. 4 positive phase 3 trials, 1 negative phase 2 randomized trial. Over 5,000 patients randomized, and the result of the trials are almost the same. By adding immunotherapy, the benefit is huge for patients who are mismatch repair deficient, and that all trials are positive for all comers, and there is a small benefit as well, significantly, statistically significant for proficient patients as well. So going back to our patient, to our clinical case, so the patient has carcinosarcoma, she has microsatellite stability, she's not mismatch repair deficient, and she was submitted to chemotherapy, and she had access, and she received immunotherapy, and she received dostarlimab because it was those patients were included in the RUBY trial. And she presented treatment response. After 6 months on treatment, she has stable disease. And when the disease progresses, what will you consider? Would you consider pembrolizumab combined to lenvatinib? But she had immunotherapy before, and patients who had pembrolenva did not have. Mismatch repair proficient patients are a heterogeneous group, and we still don't have biomarkers. What more do we need to test for those patients? So there is a revolution ongoing in endometrial cancer. So we had Megestrol approved 50 years ago, and in second line, after more than 40 years, pembrolizumab was approved for patients MSI high, and then lenvatinib combined to pembrolizumab in accelerated approval, and now we have several approvals, and this story will never be the same. So for we to treat an advanced endometrial cancer patients, now we need to understand that it's not going to be a straight line any longer. Just like the discussion we've just had for cervical cancer patients, this is not one option any longer. It's good for the patients, but it's going to be very hard for us to define the treatment. So to define the second line in the endometrial cancer, so we will, 3 years ago, we would offer for the patient carboplatin and paclitaxel, and then Doxil, and maybe Megestrol for some patients. But now second line will depend on first line. First line chemo, first line pembrolizumab, first line chemo plus immunotherapy, or first line endocrine therapy, which we still use for some patients. So if the patient had first-line chemo, most of my patients have first-line chemo because most patients in Brazil don't have access to immunotherapy in first-line so far. So if the patient had first-line chemo, if the patient is MSI high, mismatch repair deficient, we should offer immunotherapy, monotherapy for those patients based on Keynote 158 or based on Garnet trial dostarlimab, because the response rate is above 50% and the toxicity is low. For those patients who received chemo and are not MSI high, we can offer pembrolizumab, which also has a very high response rate for both patients who are mismatch repair deficient and proficient, and there is also an overall survival gain for pembrolizumab combined to lenvatinib. If the patient had pembrolizumab in first line, because we are allowed to use it if the patient had chemo in the adjuvant setting, we have a problem. We have to offer chemotherapy here, but chemotherapy has 50% response rate in the advanced setting in second line after pembrolizumab. And if the patient is exposed to RUBY, attend 18, the keynote 18, and had chemotherapy and immunotherapy in first line. It will depend. So if the patient progressed on immunotherapy, or if there is an interval between the end of the immunotherapy and the progression. If we expose our patients to chemo monodrug, the response rate is very low. It's under 20% if you offer immunotherapy alone. And should we give pembrolizumab after immunotherapy? This is renal cell carcinoma data, and it doesn't seem to benefit, the combination of pembrolizumab doesn't seem to benefit patients after first-line immuno. The benefit seems to be derivated of lenvatinib, which is an anti-angiogenic drug which is effective also in endometrial cancer. There is a Professor Vergot's trial showing that lenvatinib alone has around 15% response rate in endometrial cancer. So the combination doesn't seem to be effective. We have some case reported, but we don't have prospective data. And we are looking for more biomarkers. We cannot forget to expose our patients to first-line hormone therapy, which is an option after all lines of treatment. And we don't have data so far to use monoimmunotherapy in first line, but there are two very important trials ongoing, the Keynote 93 and the Domenica trial, testing for patients who are mismatch repair deficient, not exposing to chemo, but going directly to immunotherapy. So we need to pay attention to some special biomarkers in endometrial cancer. Hormone receptors, we are going back, we're looking for those receptors because the combination of cyclin inhibitors and hormone receptors is promising in this scenario. We need to look for TP53. It helps us to direct those patients who benefit from immunotherapy, patients who benefit from different drugs. We need to recheck mismatch repair deficient because 20% of the patients regain, can have this biomarker. And in the DUO-E trial, PD-L1 positive patients had more benefit of durvalumab than patients with negative. PD-L1 was an abandoned biomarker, which is coming back. And again, P53, a benefit for those patients who are wild type with SIENDO trial, testing selinexor for patients who benefit less from chemo. And I can't close this presentation without discussing the importance of HER2 in endometrial cancer, the Destiny Pan-Tumor 02, showing that over 84% of patients who are HER2 3+ have response with deruxtecan, trastuzumab deruxtecan. So a very important biomarker to test after first line in endometrial cancer patients. And to make the situation even more difficult, we can find patients who are multiple classifier, patients who have POE, HER2, mismatch repair deficient, and we are going to learn how to deal with those patients. So, to close this presentation, I'd like to emphasize that there are several molecular subgroups in endometrial cancer which are prognostic and predictive. There is an ongoing need to refine the subgroup, and in March 2024, endometrial cancer treatment sequencing is no longer a straightforward line. Thank you very much for your attention.
Muchas gracias, Angélica, por esa excelente presentación. Bueno, preguntas acerca de cáncer endometrio avanzado.
Yo tengo una pregunta. Thank you, Dr. Nogueira. what's your first line for most of your endometrial cancer patients? And do you treat with the same strategy carcinosarcoma and adenocarcinoma?
Based on the reclassification of the WHO, we are supposed to treat carcinosarcoma patients as epithelial carcinomas, and now those patients are being included in the trials. The problem is that it's recent and many trials haven't included the patients. For example, the carboplatin, the pembrolizumab trial hasn't included those patients, and we have some limited data, but many times I have offered for carcinosarcoma patients, and I could see the benefit. I tried to use the study where carcinosarcoma patients were included, just like the example I brought to you today. So the Ruby trial included carcinosarcoma patients. So for that patient, for that specific patient, I chose dostarlimab. But I do believe that this patient would have the same benefit with pembrolizumab. But as the inclusion criteria was that, it's easier to negotiate with those who are gonna authorize my treatment. So for first-line treatment, we need to consider immunotherapy for almost all patients. We don't have it approved in Brazil so far. There are some patients who have access, who can afford it, but unfortunately, at this moment, most of my patients with stage 4B at diagnosis would receive carboplatin and paclitaxel, and I would use immunotherapy in second line combined to pembro because it's not approved. Now we have the MSD has announced that the LEAP trial is negative, the trial which was testing lenvatinib plus pembro against chemo, so I'm not going to use lenva-pembro in first line any longer. I was using for some patients coming from the adjuvant setting, but not any longer. So I think that we should offer immunotherapy combined to carboplatin and paclitaxel for all patients, except for poly, which go very well, but it's very difficult to find a poly, especially in the metastatic setting. And probably for the NSMP patients, we don't need to give immuno, but we need to further stratify those groups.
Perfecto. Mark, Abraham, comentarios del caso de Angélica. Ok, Carlos, adelante.
Sí, quería preguntarle porque me pareció interesante que dijo que la inestabilidad microsatelital después de tratamiento podía positivizarse 30%. ¿Sí? ¿Le entendí?
20.
Ah, ok, 20. Porque no pasa eso en otros tumores y no tenemos la costumbre de rebiopsiar. Entonces está rebiopsiando. Yo tengo un caso exactamente así que lo comentamos con Mark, pero lo rebiopsiamos porque pensamos que era un segundo primario, ya como 5 años en remisión. Y no era MSS en 2 biopsias, y ahora es MSI high. Debemos rebiopsiar más de 1 año y qué marcadores pediría en una rebiopsia en una paciente.
Entonces, cerca de 20% de las pacientes ganarán mismatch repair deficiencia, que viene de metilación. Y estas pacientes en estudios previos no iban a tener tanto resultado comparado a las pacientes que eran mismatch repair deficient en el empiezo. Pero ahora tenemos datos del estudio Keynote 18, mostrando que tanto pacientes metiladas como pacientes con Lynch derivan beneficio de pembrolizumab. Entonces, si hay mismatch repair deficiencia, si hay por metilación o si es una mutación germinal inicial, la paciente merece recibir inmunoterapia. La cuestión de rebiopsiar es importante porque si voy a usar pembrolizumab, no lo necesito, entonces no es necesario. Pero si estoy en primera línea Se mi paciente hizo en primera línea quimioterapia y voy a segunda línea y puedo usar solamente monoterapia de inmunoterapia, es mucho mejor para no usar lenvatinib, que es un medicamento muy tóxico. Entonces es interesante, pero si está dirigido que voy a pembrolizumab, no es necesario. Y siempre ahora buscar HER2 en las pacientes metastáticas, porque el beneficio es muy grande, 84% es una tasa de respuesta muy alta. La cuestión es acceso. En Brasil el proceso está muy adelantado para trastuzumab deruxtecan y claro, el precio que es muy alto globalmente, pero es un medicamento muy... Estos son los más importantes. Y siempre pido también los receptores hormonales. Ahora hay datos de fase 2 de abemaciclib y de palbociclib combinados con hormonoterapia y la duración de respuesta de 9 meses. Cuando usamos hormonoterapia isoladamente, solamente 2 meses, entonces no pedíamos tanto receptores hormonales.
Sí,
Bueno.
yo sí trato de rebiopsiar, sobre todo pacientes que han recaído mucho tiempo después, en lo cual no sabemos de verdad si la patología nos dijo lo que era de verdad, sobre todo en esas patologías que se hacen postquirúrgicas, en bloques quirúrgicos, que a veces son mal fijados, los bloques mal conservados, entonces no sabemos si de verdad el perfil molecular fue lo que es de verdad. De esos tipos de pacientes yo trato de rebiopsiar siempre para ver qué opción puedo darle en segunda línea, sobre todo lo que hay ahora, porque el cáncer de endometrio actualmente es apasionante, o sea, hay muchas cosas.
De acuerdo. Bueno, nos han señalado que es el tiempo límite.